Hi, thanks again. How are you? This is Mohammed Musa from AFK Study Plan. Today we are going to continue with our new routine of weekly newsletter. And for who don't know about it, so every day we post a new question in our community and then we answer it. And by the end of the week, we collect all questions and then we give the correct answer and discuss it. And most importantly, discuss the concept and idea about these important questions. I hope if you didn't see the previous one, you can watch it here or here. Honestly, I cannot remember which side, but you can see 1, 2, 3, 4, so you can watch it at your convenience. And then here at the down, you can see the mark where you can go to specific question. And here up top, you can see this clip where you can push it. And then in the middle, you can download the whole presentation for your convenience to share it with your friends. Feel free to give me any feedback. And with that being said, let's dig deeper. First question from Proceedus. Which of the following impression material is hydrophobic? So we're speaking about the hydrophobic. Phobic mean like heat. Hydro mean water. So we aiming now to get the material which is hydrophobic, which mean hates water. We have polyvinyl siloxane, alginate, polyether, or none of the above. Before we answer, let's discuss a little bit about the impression material and different types. We have polysulfide. This is what was one of the first generation to be used. It has long working time, so you can manipulate it as long as you can, high tear resistance, a margin seen easily, and moderate cost. You would think this is amazing, why we need more materials, but it requires custom tray, stretching lead to distortion, so it cannot be used in undercut. Compatible with a stone, not very compatible with every type of stone, and most importantly, its stain closes and had bad odor, and you can pour it within 1 hour only. So it's good from this part, but like manipulation and after impression is not good. So we tried to make some improvements. So they reached to condensation silicon. It has putty for custom tray, which is good, and then clean and pleasant. It has good working time, not very long, but good, and margin easily seen. It was like, okay, this is a good solution. But again, it has high polymerization shrinkage by volatile byproduct, which is getting out after the impression is done. Mean like you need to pour immediately. And when you see immediately, usually in medical term, mean up to 30 minutes, maximum 60 minutes. It means like 1 hour. But most commonly, when they make immediately statement in the textbooks, they mean up to 30 minutes. And it's hydrophobic, so we can think about this one. And it has very big problem. It has low tear strength, unlike the other one, polysulfide. So they make some improvement over this material to make it vinyl polysiloxane. They use different mechanisms, but like it's the same concept. It has one material. You can use putty for custom tray, auto mix expense, which mean like initial cost high, but save money down the road. Clean and pleasant, not like polysulfide. Margin easily seen, ideally elastic, not very stiff, not very elastic. And you should pour immediately and stable. Delay pour, meaning like you can pour it later and pour repeatedly. And this is the most important feature in vinyl polysiloxane. So you can pour it maybe twice or 3 times and up to 1 week, which is amazing. But this material is hydrophobic. And what is the downside of being hydrophobic? We didn't discuss this one. So we said hydrophobic, it hates water. So it has no flow if sulcus is moist. And most commonly, you will have a moist sulcus when you're doing a crown to take impression. And the only way you can overcome this one is to use retraction cord with epinephrine for maybe at least 5 minutes, 7 minutes to make sure your sulcus is dry. So you make sure this material is flowing inside the sulcus. Otherwise, it will not flow, and then the lab will call you, doctor, I cannot see the finish line. How can I make your crown? And the problem more, it has low tear strength, and putty displays wash, and wash has low tear strength. Meaning like, vinyl polysiloxane has two consistency, putty and light flow. The light flow has low tear strength. So you should make a putty first and then take a wash, which mean more time. And this is not practical in the office. Putty is too stiff, and putty and wash separate like from each other and difficult to pour cast. So they make more improvement over it to reach polyether, and has amazing quality of being least hydrophobic of all elastomerics. So it does not require the sulcus to be very dry. Like when you say least hydrophobic, mean it's still hydrophobic, but comparing to vinyl polysiloxane, it's lower than. And it's fast, clean, auto mix, and margin can be seen easily, good stability, delay bore, and shelf life, meaning you can keep it in your inventory up to 2 years. But it's stiff, has high modulus, and it has bitter test, and need to block undercut. If you have undercut, you cannot use it, and it absorbs water. As we said, it's least, not like it's other way. A least component mean like has a byproduct, and most importantly, it's high cost. So they don't use it frequently. And last two is agar-agar and alginate. It's the same family. The difference between them, like agar-agar is reversible, alginate is irreversible, and it has amazing quality. It's hydrophilic. So, and it's low cost, a long shelf life, accurate and pleasant. Moist feed is okay, same for both. But agar-agar requires special equipment because it's a gel, and then you put it in a hot bath to make it a liquid. You take impression and you take it back, so it is equipment. And hot bath make the material itself to be hot, so may lead to thermal discomfort for your patient. Tear strength is very low, so it tear easily, and you should pour immediately and difficult to see margin and details. So same for alginate, and you pour immediately and can retard setting of gypsum. This is exclusively for alginate, not agar-agar. So alginate and agar-agar has a specific quality which is hydrophilic, but it has poor reproduction of details, so you cannot use it to make an impression for a crown, and it should be poured immediately, and tear strength is very low. So this is a problem with those material. So from what we discussed today, so we can reach the conclusion that polyvinyl siloxane is hydrophobic. You might say like polyester is still, but as you said, it's the least hydrophobic. So we are not going to pick it, and alginate is hydrophilic. I hope this discussion would make you on a track about impression material, because impression material is easy to study and you might see questions about it. So please study it. Second question from ortho, and I think it's a habit for me now. I put ortho question in every newsletter because I know ortho topics a little rough for most dentists because we didn't study them well back home. And when you see the question in the exam, honestly, questions are so stupid. So let's discuss the concept more than the question. Posterior crossbite with functional shift would be treated with. And then he give you option. Let's discard the option now and discuss about the posterior crossbite and how we think about it, how we think to treat it. So like you say, you know, one image has million words. How about a video? So let's see this video. It's 1 minute and then we discuss.
Patient with a unilateral crossbite. It is not uncommon for this to be the result of a constricted upper arch. If both arches are the same width, it may be more comfortable for the patient to slide in one direction or the other to allow the posterior to align cusp to fossa. This slide is called a functional shift. One clue that this may be the case is that quite often the midlines are very different. As the patient shifts to one direction or the other, the lower midline will deviate to that direction. To correct this issue, the upper arch will typically be made wider by expansion or tipping. Once the arch is wider by 1/2 tooth, the patient may no longer need to shift, correcting not only the crossbite, but also the midline discrepancy.
So I think this was easy and accurate. You can reach conclusion now. So let's just get some picture from the video and discuss about it.
Patient.
So I will just mute him. So when you have this one, so when you see patient biting, this, like you see a cross bite, first thing you should go to look here. What you are looking for? You're looking for the midline, so the canine lateral central, the other way central here, so you can see a shift. So this patient usually has a problem with his maxilla, leading when he bite like in edge to edge. And for this patient to get a relief, he cannot assume his day to be biting edge to edge. It's not comfortable for the muscles, it will be so stretching. So your body trying to compensate to reach least resistance, to be in a good shape. So he's shifting his mandible to go to right or left. And this what we call cross bite with a functional shift. So a functional shift, you see, it's a functional shift when the patient from center occlusion to center collation, there's deviation in this one. And how you can see it in the picture, you can see it was a deviation of the midline to be not coincided to each other. And this is a problem. How we are going to solve this one? Let's discuss first the posterior crossbite. So posterior crossbite is defined as any abnormal buccolingual relationship between opposing molar, premolar, or both in centric occlusion. The reported incidence between 7 to 23%. Most common form of posterior crossbite is unilateral presentation with a functional shift of the mandible toward the crossbite side, and he make it sure to be FXP. So when I say FXP, is functional crossbite with a functional shift. It occurs in 80% to 97% of posterior crossbite. So we can have another crossbite without a functional shift, but it's not very common, and you will know why now. Frequency of spontaneous self-correction is very rare. It's up to 0% to 9%. So you should intervene with this one to fix it for your patient. You are not going to wish about it. So before we dig deep for this one, we'll speak about etiology. Etiology can include any combination of dental, skeletal, or neuromuscular. They found a smaller maxillary to mandibular intermolar dental width ratio and greater lower face height, the two variable most often associated with posterior crossbite. What this mean in English term? So they found when the maxilla is little narrower than the mandible. Usually the mandible is narrower than the maxilla, but when maxilla is little narrower than the mandible, leading to this edge-to-edge bite, so patient trying to compensate for this one. And they found other etiology related to mouth breathing and correlated with the development of posterior crossbite, and they found it to be those who have been intubated during infancy also have a significantly higher prevalence of posterior crossbite. Moreover, for the etiology, I want to discuss etiology to make it clear how we can solve it. Non-neurative sucking habits, like we know kids doing this one, with development of posterior crossbite. In 2 to 6 years old American children, finger sucking habits were significantly associated with posterior crossbite. Large study of 3 years old children compared previous or continuous finger and pacifier habits with crossbite. They found pacifier use was associated with increased mandibular intercanine width and decreased maxillary intercanine width and increased incidence of posterior crossbite. So we conclude both pacifier and prolonged digital sucking and digit sucking, and this is important. So if you faced with a question saying what is the most important factor in digit sucking leading to crossbite, is prolonged, is a time. It's a time, meaning like when the patient is just doing it, like the kid is doing it, like not every now and then, every blue moon, it's nice. But like if he's doing consistently every day at night, when he's stressed, when he's crying, so the time is important. And this is like it has a very simple logic. When the child put his finger inside his mouth, he's doing sucking, and the sucking meaning like the muscles of his cheek is pushing against his maxilla, meaning it's pushing the teeth inside. When you push the teeth inside, you can know what's going to happen here. It will lead to posterior crossbite. So this is the etiology. I would like to discuss it before we speak about treatment. Differential diagnosis, we say like a single tooth occur when teeth are deflected out of line as a result of over-retention of the COS teeth. So the COS teeth over-retention is the most common etiology, leading to unilateral crossbite with a functional shift. As we said, functional shift is the centric relation to centric occlusion discrepancy. There is discrepancy. And the bilateral, which is rare due to skeletal imbalance between maxillary and mandibular transverse dimensions, differ from the one with a functional shift. Meaning this one happened in posterior bilaterally, meaning the maxilla is too constricted. So when maxilla is too constricted, meaning the patient is biting, leading to the post upper teeth is biting in crossbite. I think I lost you here, so let's see some pictures. The picture will get you back in track, okay? Oh, this is a picture. So the dental crossbite, as we said, the maxilla is good, but the teeth is tipping lingually. The upper teeth is tipping lingually to be in this side. So we have normal width of palatal vault, but the intermolar approximately to palatal width is like almost equal, but like you can see, this one is narrower than this one, and there is palatal inclination of posterior teeth. As we said, the muscle of the cheek here is pushing his upper teeth inward palatally. And when we go to skeletal one, they usually say skeletal one. So you see here maxilla is constricted. You see the narrow palatal vault here, meaning this distance AP is way smaller than CD. And you see this teeth is trying to compensate for this one. So they may be buccal inclination of posterior teeth as a compensation for a skeletal problem. Interproblem with intermolar width is considerably larger than the palatal width. As you can see, AB is way smaller than CD, or you can see CD is way longer than AB. So how you can differentiate between skeletal and skeletal and dental? So you compare this one. So or easier, you can check the inclination of posterior teeth. If you see the posterior teeth crossbite and still inclined buccally, so it's skeletal. When it's crossbite but still inclined palatally, mean it's a dental crossbite. And how, when we are going to treat it. Posterior crossbite with a function shift should be treated as soon as it's diagnosed to prevent possible asymmetric positioning and growth of the condyle. Treatment can be initiated as early as primary dentition, even 5 to 6 years old. If left untreated, this condition may lead to asymmetrical growth of the mandible. Think about it. The patient is biting this way and you do nothing for him. So this side and condyle and mandible and everything is a side will have disharmony. And when this child goes to adolescence, you cannot fix him. He need to go to surgery to fix it. So with function shift, we treat him immediately as soon as we could, even in the primary dentition. Okay? And how about without a functional shift? Without a functional shift, they say treatment can be started in early mixed dentition. You can, although it can be successfully treated in late mixed dentition. There is no evidence to support that treatment in early mixed dentition results in greater stability than in late mixed dentition. If the maxillary arch is significantly narrow with reduced arch parameter, early treatment in mixed dentition is indicated to expand the maxillary arch. So again, nothing written on the stone, but the guideline, the normal guideline, if it's posterior crossbite with a functional shift, immediately. Without a shift, you wait till he go to late mixed dentition unless it's severely constricted. So you should start it immediately. So I would like you to think about it. And then as we speak about the posterior crossbite, let's speak about anterior crossbite also. Yeah, it won't hurt, okay?
When you encounter a patient with an anterior crossbite, it is easy to assume that the patient has a class 3 skeletal tendency. But if you observe that their upper anterior teeth are retroclined, the patient may in fact not be class 3. Occasionally, the lower anterior teeth will also flare facially as they collide with the upper anterior teeth. It is important to evaluate this patient with their lower teeth out of occlusion, with their lower jaw retracted posteriorly as far as comfortable. Then, have the patient close until their first point of contact. If you notice that the patient's incisors contact end to end, the patient may in fact be actively protruding his mandible to slide past this interference. This allows his posterior teeth to come into occlusion. By bringing these upper anterior teeth forward into ideal alignment and retracting the splayed lower anterior teeth, you may be able to unlock this patient's natural bite. With this interference now eliminated, you may allow them to close in a more ideal position.
Okay, so usually when we see this view, we jump to conclusion, okay, this patient is a class 3 occlusion. Yeah, most of us doing this. But here he want to speak about this one. So it's not necessate for this patient to be class 3. They call it pseudo class 3. And how we call it pseudo class 3. So when the patient is biting, this is in class 3, correct. But like when you go to let the patient bite in the initial contact, this is not class 3. When you look here, this mesiobuccal and the groove, it's amazing. But this patient has this teeth has a problem to be inclined. So as with a posterior crossbite, patient is trying to tend his equilibrium. He don't want to bite over his front teeth. It will be very bad for the muscle of mastication. So he's trying to evade this contact, leading to a functional shift. But for anterior teeth, the functional shift is anteroposterior. For posterior teeth, it's buccolingual. This is, you can say, mesiodistal. So you don't jump to conclusion with every patient. With anterior crossbite, he's a class 3. You should look here in this upper teeth to see if the upper teeth is going palatally, is going here. So it's making this lock. So just by moving this teeth to be in front, like here, like as you see here, and the lower teeth to be a little in the lingual side, so you can fix this problem, and the patient can buy it here, as you can see, and everything will be happy for this patient and happy ending. So you don't jump to conclude like this is class 3 and we should do functional appliance or we do surgery, stuff like this. You should do first the centric occlusion and see the deflection happening for your patient. So let's speak about anterior crossbite more. So anterior crossbite in centric occlusion. So assess occlusion in centric relation first. If a class molar canine and one or more incisors is in crossbite, yes, so it's a class 1, treat maxillary or mandibular incisors to eliminate crossbite. So it's not class 3, we say it's a pseudo class 3. If class 1 molar canine and incisor interference and overjet is 0, meaning overjet is 0, meaning like it's almost class 3, but it's still almost pseudo class 3, as we said, the deflection, and then you review prognosis with parent and select treatment method. And if it's true class 3 molar canine and negative overjet, so it's complex malocclusion, true class 3 malocclusion require evaluation by a specialist. So before you jump, you need to check his patient in centric relation and then centric occlusion, and you see deflection, and then you can conclude. So here we're going to speak about if he's class 1, pseudo class 3. So you check mandibular incisors. Mandibular incisors are protrusive and spaced, like mandibular incisors is protrusive, going like labial and spaced. If it's yes, so incisors are partly malpositioned or rotated. If it's yes, and then banded and banded fixed appliance can fix it. If it's not, so patient cooperation or compliance problem anticipated. If he's compliance, so you can use maxillary lingual arch, because here we're speaking about young child, so we're not speaking about adult. We can speak about him with a diagnosis and important of treatment and blah blah blah. No, you can check his compliance. If he's compliance, you can give him finger spring. If it's not compliance, you give him maxillary remover appliance with finger spring or mandibular remover appliance with labial bow. So it depends here on the patient compliance. And here, if maxillary incisors are the other way, if maxillary incisors is retrotrusive and or crowded, yes, so you check the teeth are badly or malpositioned or rotated, so you use band and bonded fixed appliance. So the bottom line here, before you jump to conclusion, you check his centric occlusion, centric relation, deflection is functional, and then you, as we said, the same rule apply for anterior. If you have functional shift, you should treat it immediately, but depend on the compliance of your patient, because we speak about young patient. If it's compliant, you give him this line of treatment. If it's not, you give him removable, and then you follow up with him for sure, because he's still growing and you want to follow up what's going with his teeth. So I was happy to explain all this concept. I'm not here just to give you the answer. I hope this is clear for you. I think the video is clear, and then you can check it. You can watch the video again, and you can download the presentation to check it again. So here the treatment would be bilateral expansion in early mixed dentition. Why bilateral? As we said, like as you see in the video, like we have functional shift. Functional shift meaning there is little deviation in our maxilla. So we're doing bilaterally, and early mixed as it's a functional shift. So when you are going to use unilateral expansion, we are going to use unilateral expansion when you have posterior crossbite unilateral without a shift. This means the maxilla in one side, like think about it, he had the box while he was young, so his maxilla in this side growth, like in the transverse aspect, is retorted. The maxilla here is collapsed. So you should do it unilateral. And how you're gonna see it in the patient mouse? It will be unilateral without a shift. Without a shift meaning it's a skeletal problem, so you fix it this way. So, and we said late mixed, we are not going to wait for late mixed because it has a functional shift. Hope that was clear. Just watch it again and you'll get the concept. Third question from surgery, and the last 3 questions from surgery. I don't know, I didn't realize it, but like once I was doing the presentation, I was like, wow, this is a surgery newsletter. An envelope flap that is 6 mm in comparison to 12 mm will have 50% faster healing, 50% slower healing, healing that is twice as fast, healing that is twice as slow, the same healing time. And there's a super tricky question. It will have the same healing time. The length has nothing to do, because like if it's 100 meter in length, the flap is healing in a horizontal plane, is not healing in a vertical plane. So being 6 mm, being 12 mm, being 10 mm make no difference, as healing is going in the horizontal plane. You have 2 flap sides, you retracting them together, and you suture, that's it. But this question is aiming to give you a concept so you don't think, okay, while we're doing extraction, let's make a small flap because it will heal faster. And this is critical. We speak about it in a lecture. I can give you the link here. You can see it about flap design, suture, everything. But a quick recap here. While we are doing a flap, we should make the base wider than the top of the flap, and we should make it as much as we could as envelope flap. There is no vertical raising incision. Why? Because like any vertical raising incision will lead to a recession here. And the vertical incision, it should be not in a mid buccal, not in the dental labella, it should be midway between them. As we said, this is wider than this. And as you can see here, when we go to do envelope flap, we are going to go 2 teeth anterior, 1 teeth posterior. If you are going to do vertical receding incision, we are going to go 1 anterior and 1 posterior. And as you can see here, the vertical receding incision is almost always mesial, not distal side. And we're going to discuss this later. You can see it in the lecture because I don't want to waste time here. But the most favorable one for impacted lower 8, it would be envelope flap. If you are going to make it 3-corner, the mesial incision, vertical receding incision would be in the mesial side, not in the distal side. And lastly, this is the most important factor, how to prevent dehiscence. So you can think like why you are going to go here. We can just go the incision here. So if you do it here, the flap here will be stretched. And when you retract it with your Minnesota retractor here, you will damage this part. When you damage this part, you retard the healing by blocking the blood here, leading to necrosis and inflammation for your patient and complication. So that's why we discuss about the length. Length has no factor to treat your soft tissue in a delicate way to make sure it's retracted in a good way, not collapsed here. So you will have a better prognosis. You will have a happy patient after this. If you keep doing this, your patient will not be happy and you will not sleep for a few days. Just think about it, like if you have a flap necrosis, it will be extremely painful and the patient will not let you even sleep. So here it was a tricky question. The length has nothing to do with the healing in horizontal plane. So it will have the same healing time. Again from surgery. A patient present after surgery with a small swelling in the mucosa. The patient has no pain, fever, or lymphadenopathy. The most appropriate management is giving you for option observation, antibiotic, anti-inflammatory, curettage. And I would like to explain this in a detailed way, so please bear with me. After you listen for the next 2-3 minutes, you will be good with complication after exo and how you think it's a complication or normal. So first thing to be said, you should speak with your patient to let him know pain is anticipated, swelling is anticipated, and you are going to give him instruction. Patient should be instructed to bite firmly on the gauze for at least 30 minutes and not to chew or on the gauze. The patient should hold the gauze in place without opening or closing the mouth, and you ask him to talking should be kept to minimum 2 to 3 hours. And if he's a kid, you can say like one day his parents will be so happy with you. And then speak with the patient about what he's going to see after he's going home. Side to ooze slightly for up to 24 hours after the extraction procedure. So if a question saying the patient call and he's saying that it's oozing within 24 hours, what you are saying to him? Nothing is normal, just bear with it. Nothing will go for you. If the bleeding is more than a slight ooze, the patient should be told how to reapply a small piece of gauze directly over the area of extraction. And then if it's not controlled, in place for as long 1 hour to gain control of bleeding. Further control can be attained if necessary by patient biting on a tea bag for 30 minutes, and this because of action of tannic acid. A regular tea serves as local vasoconstrictor. So here we speak about what the patient is going to anticipate. Biting 30 minutes, keep it talking minimum for 2 to 3 hours. Oozing for 24 hours is normal. Slight more, change the gauze if still you bite on a tea bag for 30 minutes. Okay, this is good. And then patient who smokes should be encouraged to avoid smoking for the first 12 hours or maybe 1 day if it's must. Okay? So how about pain? All patients accept a certain amount of discomfort after any surgical procedure. It's useful for dentists to discuss this issue carefully with each patient before procedure because like if you are going to do extraction for lower teeth which is mobile, it's not like doing extraction for vertically impacted upper 8. It's different. The surgeon must help the patient to have a realistic expectation of what type of pain he may occur or correct any misconception on how much pain is going to have. And then we are going to speak about timeline here to be more specific. The pain a patient may experience after a surgical procedure such as a tooth extraction is highly variable and dependent to a great extent on the patient pre-operative expectation. Again, he speaks about expectation again, again, and again. The pain is usually not severe and can be managed in most patients with mild over-the-counter analgesics, so we are not going to give him medication. The peak pain experience occur about 12 hours after extraction and diminish rapidly after that. So you are going to tell your patient pain is anticipated up till 12 hours. After 12 hours, it's going to go the other way. Significant pain from extraction rarely persists longer than 2 days after surgery. And here is the cut off. So we speak about the pain. It will be high in the first few hours. 12 hours will be the peak and then decline. And the pain rarely persists longer than 2 days after surgery. So up to 2 days, if patient call after 1 day saying I have a severe pain here, so you over-the-counter medication and it's good. And here, like very good advice, might be asked about it. The first dose of analgesic medication should be taken before the effect of local anesthetic subside. So you're letting your patient know you take your medication before the freezing is gone, because this will give him a coverage not to feel pain. As we said, like the pain most commonly coming in the first 12 hours. Now let's speak about edema. Many surgical procedures result in a certain amount of edema or swelling after surgery. Routine extraction and single tooth will probably not result in swelling that the patient can see. However, extraction of multiple impacted teeth with reflection of soft tissue and removal of bone result in moderately large amount of swelling. Swelling usually reach its maximum 36 to 48 hours. So pain up to 12 hour, swelling 36 up to 48 hours. So again, patient calling you second day, like not first day, second day, and saying the swelling is high, swelling is big, swelling. What can I do for this? You do nothing. You tell him it's normal up to 48 hours, especially if it's impaction tooth, like this one. Back to left maxillary and mandibular third molar performed 2 days before this photography was taken. The patient accepted a moderate amount of facial edema. I don't know how they think it's moderate, but anyway, which resolved within 1 week of surgery. So it's good. You just tell your patient it's good. And here I think, and the textbook is speaking a lot about this one, experience, expectation of your patient. When your patient see you panic, he panics. When the patient see you, you are in a calm way, you are confident, you did discuss this before, the patient will be less like this patient's wife will most probably think, oh, you should call your doctor. And then he said, no, doctor say this is normal. I will just apply a call back. It will be normal for me. It's nothing to worry about. So expectation is very important. Swelling begin to subside on the third or fourth day and is usually resolved by the end of the first week. Increased swelling after the third day may be an indication of infection. So to wrap it up, pain up to 48 hours is good. Swelling in the 48-hour is normal. Swelling should be going the other way in third or fourth day. In the fourth day, increased swelling. On third day, increased swelling mean there is bad news here and you might have an infection. How we are going to do this one? How we are going to prevent and recognize infection? These principles are to minimize tissue damage, remove source of infection, and cleanse the wound. So he speak here about the technique you are going to use for your patient inside the surgery, how to prevent it. No other special measures need to be taken with average patient. However, some patients, especially those with depressed immune host defense response, may require antibiotic to prevent infection. Antibiotic in this patient should be administered before the surgical procedure and not after. Infection after routine extraction are unusual. The typical signs are development of fever, increased swelling, redness of skin, and a foul taste in the mouth, or worsening pain 3 to 4 days after surgery. So I think with that being said, I think you can get to conclude what patient is going to anticipate, how we are going to deal with him. To cut it short for you, pain go to max 12 hours after surgery and subside in 48 hours. Bleeding, oozing in the first 24 hours is normal. If it's more than oozing, you ask him to change the gauze for 1 hour again. If it's still oozing, you ask your patient to get in a tea bag for 30 minutes. If it's still oozing, then you are going to intervene. So I would like you to think it this way. You don't jump to conclusion because they tend to ask question in these small details. Because usually, honestly, we tend to jump to conclusion. This infection come, I will do curettage, give him freezing. This is not usual because you are aiming for nothing. This is normal for your patient. You just need to wait. And swelling, as we said, up to third day is normal, especially with impaction. In third day, it should subside in fourth day and go away in 1 week. If it's increasing, fever, pain, lymphadenopathy happening for your patient starting from third to fourth day, so you have infection here, you should intervene. And for medication, no antibiotics, no analgesics, you just make observation. So no antibiotics unless it's medically compromised, no anti-inflammatory, you just make him OTC, over-the-counter medication, no curettage, and please, no curettage for dry socket. No curettage for dry socket, because this is like, I see most dentists, like for dry socket, they pick curettage and antibiotics. It's not to be done. I had dry socket 3 times in my miserable life, and it was so painful. And my dentist refused to do curettage. I begged him to give me antibiotics. He was like, "Don't tell anyone about it, but you shouldn't give antibiotics and you should do curettage." The rationale here, curettage, they don't know the etiology of dry socket, so they think it might be subclinical infection. So if you are going to do curettage, you may push the infection deep down in your bones, so may lead to osteomyelitis. So he didn't do it for me, and I was crying so hard. He gave me antibiotic, and he told me it will do nothing for you, just for your convenience. I was like, thank you, give me the prescription. Last question from surgery, and this question I love it because this question was asked by one of our dear doctor in our WhatsApp group, and I did pick the answer wrong, and he corrected me, and I'm so happy about that because this is the core of this website, and here we are here to learn from each other, to study together, because I know the process is very hard. So I'm here to offer you extra hand, to offer you some references, just to study together to reach a conclusion, and then you can pass your exam. So the question was, which nerve is mostly damaged in TMJ surgery? And then he giving you these numbers, and you go with these numbers, and if you don't know this number, you will be in a deep trouble, because like if you don't understand this one, you cannot get it. So he speak about number 5, number 7, number 10, number 3. Number 3 is a way far away from TMJ, so you don't care about it. So, and number 10 is like vagus nerve, it's here, it's far away, but anyway, so you are confused between this one, number facial nerve and trigeminal nerve. So which one is the most commonly damaged? I answered this one. And I think I was mistaken. Oh no, I answered this one. I think I was mistaken. So let's check the reference, what they say about it. The facial nerve could be considered the second most important structure at risk during arthroscopy of the TMJ. Why? Because they're saying there is intersection between the anatomy of the facial nerve and the technique of doing the surgery. And I will show you a picture here now. And they say classical lecture has described a safe zone approximately 0.8 to 1.8 millimeter in front of tragus and approximately 10 millimeter inferior to the root of glenoid fossa. The concept is with placement of a scope along the posterior portal at approximately 10 millimeter seems to be very safe and blunt dissection. So let's speak English here. So before we go to picture, let's here speak about the other nerve. So they say cranial nerve trigeminal, particularly its third division, can also be damaged, like a mandibular one, during the arthroscopy. How? Patients report some numbness to their lip or teeth accordingly. This seems to be more the result of a swelling because of the nerve itself is not in the surgical field. So I was mistaken when I picked this one. And he said here, you may find this complaint from your patient, but it's not related to the surgery itself. It's not related to the cut during the surgery. It's related to the inflammation and swelling in this one, pushing upon the mandibular, the third branch of the trigeminal, leading the patient feeling this numbness. But the one with direct relation, anatomical relation with TMJ is the facial nerve. And let's see the picture here. So here, how they think about it. There's a facial nerve, and they say you should go this way, and this is more clinical picture. You should go within this line, and they go with, like here you see a picture like it's away. Here it's more inside the line because like this will lead to a scar, which is can be seen in the patient face. So they tended to be more plastic surgery to be here, to be away from this. And then you might think, okay, so why are you saying this is the second most? I will give you the first most, which is the maxillary artery. So why maxillary artery is more important? No, it's not like more important, but as you can see here, the like you see the diagram here, this one is down and you're going to cut here, but you think about the facial maxillary artery is just overlapping this cutting we are going to do here, like because the cutting would be most commonly here, and there is most like this is more important reason because like you know the Van rule saying when we go from superficial to deep, you are going to see vein first and then artery and then nerves. Nerves tend to be deep inside, deep down the skin. This is from the engineering of God about this one. When you have some injury, it will go to vein. Vein is important for sure, but like it's less important than artery. Think about injury leading to into artery. It will lead to more bleeding, more risk for your life, and for sure nerve is deep, deep. So to be away from this one, and you can see here the facial nerve is going back and some tendons here. But anyway, the most common or the most important not to be injured is maxillary artery, followed by facial nerve. It's not the trigeminal. As we said, trigeminal and numbness leading because of the swelling in the site of the operation pushing over the mandibular branch. It's not like because of the direct relation during the incision and the surgery. And then we have our answer to be the facial nerve. Please, I would recommend you to know the names because sometimes like Ramsey Hunt is though is affecting which nerve, and then you go in facial and you don't see facial. You see this beautiful symbols, so you should understand them, not to be tricked about them as they did to me. Okay, that was all for today. Thank you for watching till the end. I hope that was beneficial for you. We're still doing our mock package for the people attending the mock package. Tomorrow will be the discussion for the second paper of mock 1. They did mock 1, mock 2. We are going to do the discussion for mock 2 next week. I hope that's all for that's everything for today. Have a good night as usual and see you next week.